Okay, so week 1, we're starting with biliary tract and upper gastrointestinal system, commonly called upper GI system or upper GI tract. Okay. One second. All right, so we're going to start with the biliary system. Okay, so we have the liver, okay, and the gallbladder, which is going to be behind the liver. Now, the liver occupies the majority of that upper right quadrant, okay, of the abdomen. So it's going to be right under the diaphragm, as you can see. Now, on chest x-rays, you'll notice normally that the right diaphragm is usually higher than the left diaphragm. And this is why, because of the liver pushes it up, okay? When we look at our kidneys, okay, on a KUB, sometimes the kidneys can show up very faintly. One of our kidneys normally is lower than the other. It is the right kidney that will be lower than the left one. Why? Because the liver pushes it down. So one thing that we're going to learn in this course is how adjacent structures and organs affect others, okay? So certain organs are positioned in our bodies in certain directions and positions due to other organs adjacent to them, okay? So again, it's important that you know, and you learned this when you were reviewing abdomen in your previous courses, the different quadrants, right? Right upper quadrant, a left upper quadrant, left lower quadrant, right lower quadrant. Okay, so it is important that you know where these organs lie, have a general idea, okay, where these organs lie. So the liver is located in the right upper quadrant. Okay, the spleen is located in the left upper quadrant. Okay. So here we have an anterior view of the liver. Here's a posterior view. So anteriorly, we have a right lobe, a left lobe. Posterior view, we also can see the caudate lobe and the quadrate lobe. Okay, the gallbladder is located on the posterior aspect of the liver. And then this is the biliary route. This is an image, this diagram you will probably see in some of on one of your quizzes assignments. So make sure that you remember this image and that you know the route. Okay, so it starts with the right and left hepatic ducts into the common hepatic duct, then the common bile duct. Okay, right, left hepatic, common bile duct. Okay, then the common hepatic duct bifurcates and goes into the cystic duct into the gallbladder. Okay, and the common bile duct is going to empty, along with the pancreatic duct, is going to empty into the duodenum. Okay, the duodenum is the first portion of the small intestine. So in this course, anatomy, you guys, is very important. You will need to brush up on your anatomy, just like you did with bony anatomy, but now it's soft tissue, okay, organs. And you want to be able to know where this anatomy is located, the position of the anatomy within our abdomen or our bodies as well. Okay, this is the gallbladder. It has a neck, a body, and a fundus. Okay. Functions of the gallbladder: storage of bile, concentration of bile. Okay. This is just showing you kind of a close-up of the common bile duct, the distal aspect of it, the common bile duct. We have the pancreatic duct, as I mentioned, emptying into the duodenum, okay? Specifically speaking, the descending duodenum, okay? Okay, so this is a side view of the abdomen, okay? So someone sliced, the abdomen in the mid-sagittal plane, okay? So this is just so you are able to visualize the relationship between different organs, okay? So this is the anterior aspect of the abdomen. This is posterior because here I can see spine, okay? So we have the liver, the gallbladder posterior to the liver. We have the kidneys back here. We have the duodenum, and then some other, the small intestine, large intestine, okay? Okay, so what we're looking at here is an image of the gallbladder. The only reason we're able to visualize the gallbladder is because of contrast. It looks white because there's contrast. Without contrast media, okay, we would not be able to see anything. Okay, remember we had the neck, the body, the fundus. And by looking at this spine, what position are we in? Can anybody tell me what position this is? Look at the spine, look at the anatomy. We start to see something forming here, right? What do we see in the L spine? Exactly, obliques, because why? We see Scotty dogs, exactly. Very good. We see Scotty dogs. We have the pedicle, the ear, the nose, neck, leg, okay? So this is an oblique. And that's something that's really important because you're going to have to identify, not specifically speaking of the gallbladder, but let's say the stomach, and it's going to be an image of the stomach with contrast, and you're going to have to tell me what position is this. And sometimes it can be hard. So what are you going to do? Look at surrounding anatomy. Look at your spine. The spine is very telling, okay? So the spine will let you know if it's an AP, if it's a lateral, if it's an oblique, okay? Okay, okay, so this is anatomy of the biliary duct. So that little diagram that we were looking at, that's this, but in real life, okay? With contrast media injected into the biliary ducts. This is what we call an operative cholangiogram, okay? So we are injecting contrast media into the ducts to make sure that they're nice and patent, that they're open, that they're not being blocked, that we don't have any stones blocking these ducts. And we're going to talk more about that. This is just image of a gallbladder under sonography. Okay, so today we're talking about the upper GI. Next week we'll be doing the lower GI tract. Okay, so we're going to be talking about the esophagus and the stomach. So the common radiographic procedures for upper gastrointestinal system are esophograms. So an image or an exam or study of the form and function of the pharynx and the esophagus. So what we're looking at here is the esophagus filled with contrast media. Again, this is an oblique, right? Because if we're looking at the spine, and you can look at the clavicles, this patient is rotated. This is an oblique. We also have, this is an image of an upper GI exam. Okay, this is the stomach. By the end of this lecture, you will be able to identify based on looking at an image if this is an AP or a PA. Okay. So the purpose of an upper GI is this to study the form and function of the stomach, the distal esophagus, the stomach, and the duodenum, which is the first portion of the small intestine. Okay, accessory organs in the mouth. So we have our salivary gland, so parotid gland, the submandibular, also called submaxillary, and the sublingual. The pharynx, okay, so the pharynx has three parts. So we have the nasal pharynx, we have the oral pharynx, and then we have the laryngopharynx, which then goes into the larynx, okay? Okay, So the esophagus, this is a side view. Okay, so it's important that you know the relationship of the esophagus to other structures. And this is something that is very commonly confused. The esophagus, you guys, is posterior to the trachea. Trachea is in the front, esophagus is in the back. Okay, so trachea is this structure here, esophagus is posterior to the trachea. Okay, so it goes down. So the esophagus begins at around C5, C6 and extends all the way to T11. It pierces through the diaphragm, okay, and connects with the stomach. Okay, so this is the stomach, this is the esophagus, right? And notice there are two indentations, okay? And if we didn't know about anatomy, we would think, well, that looks weird, right? This looks maybe like a stricture. That doesn't look normal. Why is it indenting that way? Especially under fluoro with contrast media, it could look like pathology if you didn't know your anatomy. That's why anatomy is so important, you guys, okay? So these are natural indentations formed by other surrounding anatomy. So this is the aorta. This is the aortic arch, okay, going down. So the first indentation is caused by the aortic arch. The second indentation is caused by the left primary bronchus. Okay, so those are natural indentations of the esophagus, okay, because of other surrounding anatomy. This is an inferior view of the diaphragm. So piercing through the diaphragm, we have the esophagus, like we mentioned, inferior vena cava, and the aorta posterior to the esophagus. This is an inferior view. This is a side view. Okay, so this is an image of an esophagram. Okay, so we see the esophagus emptying into the stomach. Okay, so this is an RAO. We're going to learn more about the different positions. So in this course, the way every lecture is going to be, you guys, we're first going to talk about, we're going to review anatomy, because you need to know your anatomy before you learn positioning, because how are we going to know what to position or how to position if we don't know and understand our anatomy? So we're going to review anatomy, then we're going to go into some pathology. Okay, I'll try not to be too long on pathology. That stuff you can kind of review and brush up on your own because they're basically just definitions. And then the setup of the exam, and then the actual positioning, okay? So this is, remember that natural indentation, okay, caused by the aortic arch, then the second indentation caused by the left primary bronchus. Okay, so let me see here. Okay, so we're going to start with the anatomy of the stomach. Very important, you guys. Okay, so the stomach is kind of like a backward C. It has the shape of a backward C, right? Okay, backward C. Okay, it has a fundus at the top, it has a body, and then it has the pyloric region. Okay, so let's go to this image. Okay, so the main parts, it has three main parts. The most superior portion is called the fundus. Then we have the body, which is the largest portion. And then we have the pyloric region, which is the portion at the end that connects with the duodenum. Okay, we have the esophagus, right? And it's going to connect to the stomach. So this is called the EG junction, esophagogastric junction, or the GE junction. Some call it the gastroesophageal junction, also called the cardiac orifice. It has many names, okay? But you should probably just go by esophagogastric. It's the easiest to remember, okay? We have a lesser curvature. We have a greater curvature. Whoops. Okay. Again, fundus, body, pylorus or pyloric portion or region, greater curvature, lesser curvature. Okay. Then we have the EG junction, the esophagogastric junction. Okay. We said backward C. So this is inside. of the stomach, okay? And these little folds here, they're called rugae. They're mucosal folds. So this is what your stomach looks like on the inside when it is not expanded, okay? So when this is what it looks like, these mucosal folds, very characteristic of the stomach. So when we insert barium inside the stomach, you will be able to see those squiggly lines. Okay, so this is a real image of the stomach with contrast media, okay? This is barium specifically. So this is the fundus, okay? Then we have the body, then we have the pyloric region, lesser curvature, greater curvature. Then we have the duodenum, okay? Remember, duodenum is the first portion of the esophagus. Remember, air looks black, contrast will look white under X-ray, okay? Air is black, barium or contrast will appear white, okay? So notice the fundus, it's dark, right? It's black, and then the body is white. Okay, this is telling us something, and we're going to learn about that in the slides coming up, okay? This means that there's air in the fundus, okay? And that's going to tell me what position I'm in, if I'm AP or PA. Okay, so this is a really important slide. This is pertaining to stomach orientation, okay? It's all about the orientation of our organs, okay? When we insert contrast into them, the contrast will move in certain directions based on the orientation of that organ, okay? So again, we said the fundus was the most superior, okay? So this is an AP view. This is a lateral view, okay? You can see the spine, okay? This is the patient's back. This is the anterior surface of the stomach. So it's a backward C, okay? If you make a C with your hand, make a backward C, now point that C towards your abdomen. Point it directly at your abdomen. That is basically what your stomach really, the way it really sits in your abdomen, okay? It's a backward C, okay? So the fundus is the most superior, but also the most posterior. So the fundus is the part that is closest to the spine. The body is the most anterior, okay? And the pylorus is going to be the most inferior or distal, and also goes back posteriorly. But the most posterior part of the stomach is the fundus, okay? So it goes back, forward, and back, okay? Now, I like to do, this here. Let me do something here, you guys. Okay. I want to show you guys something, okay? So if I take this image, okay, remember, this is the patient's back, and this is the patient's tummy, okay? Now, I'm going to turn this patient on their back, okay? So this way, right? So pretend there's a table here, they're on the X-ray table, they're laying on their back, okay? If we give this patient anything to drink, okay, where would the majority of that liquid go? Remember, gravity, look at the orientation of the stomach. You give somebody something to drink in this position, where will the majority of that liquid go? Exactly. In the fundus, to the part that's closest to the spine, gravity, right? Remember, gravity is going to pull things down. So, very good. Yes, the fundus. So fluid settles, air rises, right? So if I give this person something to drink and put them in the supine position, all that contrast media is going to go towards the fundus because it's the most posterior portion. Now let's turn them on their stomach. Whoops. Let's turn them on their tummy now, okay? So now my table is here, and this patient is on their stomach. Where will the contrast go now? Where will the liquid go now? Is it going to stay in the fundus? Exactly, the body, it's going to drop, right? It's going to leave the fundus and it's going to hang around in this area, okay? That is what I need you guys to understand or get from. If there's anything you get from this lecture, that is what you need to understand, okay? Because we're going to have to identify positioning based on contrast media, okay? So let's go back. Okay. Now, this is an air barium distribution diagram here. So remember, barium is white, air is black. So this one is with your patient supine, this one is with your patient prone, laying on their tummy, and this one's just standing up at the wall bucky. Okay, so let's start with this one because it's the easiest to understand. This patient is standing up at the wall bucky, erect. Barium settles, right? Fluid, liquid settles. So all the barium is down here and air rises. So air will be in the fundus region. Now, this patient here, they are supine. They're laying on their tummy. Remember, we said the fundus is the most posterior portion of the stomach. So if you're laying on your back, all that contrast will go to the fundus. Okay. Now this patient is laying on their tummy. Remember, they're laying on their stomach. Okay. The body is the most anterior portion of the stomach. So the barium is going to leave the fundus and will now be in this section in the body. So air will be in the fundus. So that black that I showed you guys on the other image, that was air. Yes, very good question. So if there is a perforation in the stomach, it would leak out. Now, it wouldn't be like a leak where it's explodes and everything's outside. Like it's usually very, small, faint, but you would be able to see under fluoroscopy, you would probably see some barium. You would turn your patient in different positions to kind of figure out exactly where it's coming from. But yes, you would be able to see it in the peritoneal cavity. Very good. Okay, so this image right here, you guys, based on what we just covered, what position is A? Is A supine or prone? So this is considered the fundus. This is air. That blackness, that is air in the fundus and contrast media in the body. Okay, so is this patient supine, AP, or PA, prone? Prone, very, very good. And it can get tricky when you're actually looking at a real image. Yes, this patient is prone. They're laying on their tummy. Okay, so the barium is going towards the most anterior surface of the stomach, which is the body. Okay, now we can't expect for it to look like this, right? Okay, or exactly like this, like a definitive line and a big difference between the air and the barium. In real life, this is what you get. Air in the fundus, barium in the body, okay? All right, now let's look at B. Now we have barium in the fundus, and air in the body. So barium in the fundus, what does this mean? Remember, the fundus is the most posterior part of the stomach. So if you're laying flat on your back, where is that liquid going to go? Remember gravity. Very good. Supine. They're laying on their back. Okay. All that barium went to the fundus. And remember, the pyloric region is also posterior. So there might be some in the pyloric region as well, but the body will be filled with air. Very good. Okay. So again, supine, this is a better one. Barium in the fundus. This kind of looks like a seal or a walrus or something to me. So this is barium in the fundus. Therefore, our patient is lying on their back. They're supine. Okay. Now this one, we do see that there is air in the fundus now, right? So this means that this patient is in some sort of PA. Okay. They're in an oblique specifically. Okay. So an RAO is a prone oblique, right? The right anterior side is anterior, is closest to the image receptor. Okay. So you will be able to identify this as an RAO once we go over the specific positions for an upper GI. Okay. But just keep in mind, there is air in the fundus. Okay. You see Scotty dogs here? That's what I'm saying. Look at surrounding anatomy. There's Scotty dog right there. So this is a form of oblique. Okay. Because I see a Scotty dog there. Can't be just straight AP or PA. This is some form of oblique because I can see that Scotty dog there. Okay. So this has to be a prone oblique. Why? Because there is air in the fundus. So it's either an RAO or an LAO. Okay. And the reason why I know it's an RAO is because the positions that you're going to learn for upper GI, one of them is an RAO. We don't really do necessarily an LAO too commonly. Okay. All right. Moving on to the duodenum. Okay. It's also in the shape of a C. It hugs or it surrounds, it curves around the pancreas. Okay. So that's why this is called the romance of the abdomen, because, they're close together. They're very romantic there. Okay. Different parts of the duodenum, don't really need to know this. A summary of mechanical digestion. Okay. Can skip over this. Okay, body habitus. So this is what your discussion one will be about. Body habitus plays a big role in positioning, right? And because of our organs orientation. So for a hyperstenic patient, we go crosswise for chest, right? For a super astenic patient, we go lengthwise for chest, right? Things like that. So we know that the lungs change based on our body habitus, but so do the rest of our organs. So this is the stomach. If we look at this hyperstenic patient, their stomach is almost horizontal, right? And when we compare it to the astenic, it hangs really, really low, all the way down into the iliac crest area. Okay. So this is stenic, our average patient. Then we have astenic and then hyperstenic. So what is important to know, and you will see on the quiz or the assignments, is this. Okay. So let's see here. You're going to want to be able to identify the duodenal bulb and the gallbladder for hyperstenic patients, stenic patients, and astenic patients. Okay. And so that's this. This is the gallbladder. Okay. The gallbladder. But they also are referring to the duodenal bulb. Now, the duodenal bulb is this section. Where is the duodenal bulb? Is a very important area for radiologists to see during an upper GI. Let's see if I can get, so for example, right here. would be the duodenal bulb, because it's an area where a lot of ulcers can grow. Okay, so that's why we do this RAO, this side view, this oblique position, so the radiologist can get a better view of the duodenal bulb. Okay. Now, depending on the patient's body habitus, the duodenal bulb and the gallbladder will be located at different vertebral levels, which is very important to know. The registry will ask you this as well. Okay, so on a hyperstenic patient, remember it's going to be the highest, T11, T12 for hyperstenic patients. Let's see. That is a really good question. So if they do lose weight, their body habitus will change, and so will their organs. They will move. Just think about when a person is pregnant, due to the uterus being filled with the baby, right? The fetus that's growing, everything is pushed up. Okay, everything is pushed up. So your stomach is higher, all your organs are being pushed. Okay, so yes, that is a really good question. If they gain weight or they lose weight, yes, your organs will adjust accordingly. Okay. So stenic, I would just probably remember stenic, okay, is L1, L2, okay, that's average. Hyperstenic, remember, is going to be higher because the stomach is higher. And then astenic and hypostenic all the way to L3, L4. Okay, so very close to that iliac crest. So make sure to know these. Okay, body habitus and duodenal bulb and gallbladder. Okay, now if we're doing an upper GI and we have to center at the stomach, that's important to know. So when we're centering for an upper GI to take stomach pictures, we need to know where the stomach is going to be oriented, right, and located based on body habitus. Okay, so here we have, let's say if you see this image on an exam or one of the assignments, okay, and without this, and I ask you, what body habitus is this? You should be able to say hyperstenic. Why? Because you see that it's labeling T11, T12, okay? L3, L4, I know that that's astenic, right? L1, L2, that's stenic. Okay, and here we have the different, like this. So if I show you, you will see these images actually on an assignment or a quiz. I'm not sure which one. You might see this one, this one, this one, or all of them. Okay, if you see this image and I ask you what the patient's body habitus is, you should be able to say hyperstenic because it's labeled T11, T12. Remember, I said, remember these. If I should give you this image, you should be able to say this is an astenic patient because first of all, look how low that is, but it's labeled there for you. This is the answer. This is giving you the answer, okay? So that is what you need to look for. You might look at this and say, well, how am I supposed to know what the body habitus is? Well, these are your answers, okay? L3, L4, astenic, L2, L1, L2, remember we said that was stenic, T11, T12, hyperstenic, okay? Okay, so contrast media is required, right, for upper GI procedures, for any of these procedures. So this is an AP abdomen without contrast. This is an abdomen with contrast. Big difference, right? Fluoroscopy. So the ability to view and record anatomy in motion. Okay, so these are live X-rays. Then we have different types of contrast media. This is barium sulfate. Okay, so we mix this with water and it gives us this barium contrast consistency. Okay, barium is a positive. Okay, it's a positive contrast. Air is a negative contrast. Okay, barium is positive. It's a chalk-like substance and it does have a chalky taste. It doesn't taste great. You do want to be able to explain that to your patients. They absorb more X-rays. Okay, that's why it appears as white on imaging. Okay, air is black. X-rays go right through them. Okay, and it shows up as black. Okay, when X-rays absorb a lot of something, it's going to show up as white. Okay. So barium never dissolves in water. Okay, it's a colloidal suspension. Contraindications, that's another thing. With fluoroscopy, you guys, in advanced imaging, patient history is essential and knowing what the contraindications are for. So let's say we were talking about a possible perforated stomach earlier, right? So this stuff, barium sulfate, it never dissolves. It does not dissolve in water. So if we have a patient with a possible perforation in their stomach or viscous, anywhere in their abdomen, and we give them barium, what's going to happen? This barium is going to leak out into the peritoneal cavity, and it's going to stay there. Okay, it's like this chalk-like consistency, and it becomes hard and it's heavy. Okay, so this patient, if enough of it has leaked out, they will have to go to surgery. So contraindications for barium is perforated viscous or pre-surgical procedure. If your patient has had recent surgery, you don't want to give them barium, or let's say they're scheduled for surgery tomorrow, you also don't want to give them any barium. Okay. It's like cement, essentially. If you just let this barium sit there, it will begin to separate and it's going to be very, very heavy. Thick barium, thin barium. So the ratio of thick barium is 3:1 or 4:1, thin barium 1:1 of barium to water. Okay, then we have water-soluble contrast media. Okay, this is different. Okay. We use water-soluble contrast media when we have a contraindication for barium. So let's say we're doing this exam for detection of a possible perforation, or let's say your patient has just had surgery, or they're scheduled for surgery. We will give them water-soluble, okay, contrast media, because it dissolves in water. So your body will absorb this type of contrast media. It's called water-soluble. Indications for perforated viscous pre-surgical procedures. Now, contraindications to this is having an allergy to it. So you always want to ask your patient, do you have any allergies? Do you have any allergies to iodine? Okay, if they say yes, you do not proceed and give them water soluble. So at the end of the day, all of this will be decided by the radiologist. They will be the ones to say, okay, we're going to give them barium or we're going to give them water soluble, but you're the one that's responsible for taking that history initially, letting the radiologist know, okay, and then he or she will make that decision. Okay. Okay, so we have different, so we talked about barium as contrast, and we talked about water soluble as well. Okay, now with barium, we can do two different types of exams. One of them called a single contrast, the other one called a double contrast. Single contrast involves just barium. Double contrast involves barium and negative contrast, which in this case would be room air or carbon dioxide. We want to use a double contrast like you see here if we're trying to visualize the mucosal lining, so the outside and more of the lining of the stomach. Okay, so you're able to see all that rugae. Okay, if we're just if we're not concerned with the mucosal lining, then we can just do a single contrast. So the exam, when it comes to the department, will be ordered either as double contrast or single contrast. Okay. So this is what a double contrast looks like. You can see the rugae, the mucosal folds are demonstrated on a double contrast. Okay. Whereas on a single contrast, you can't see the rugae, right? It's just filled with, it's superimposed with the barium, okay? So let's say we're doing this for possible, ulcers, or maybe trying to find some sort of polyp or something, okay? You need to do a double contrast. Digital fluoroscopy, I'm not going to go into this too much because I know Mr. Dawes is talking about this. Okay. And then we go into radiation protection. So this, you will bring the bucky all the way down to have this shield in place. Okay, so let's say you're doing an upper GI, you want to bring it down this way towards the feet. Okay, distance is the most effective method of reducing dose during fluoroscopy procedures. Lead apron should be of 0.5 millimeters of lead. Okay, now we're going to go into indications. Why would we perform an esophagram? Why would you ever need an esophagram? So these are all the indications. Really common one is reflux, right? Esophageal reflux, or maybe a foreign body obstructed, hard trouble swallowing, so dysphagia. Okay, now these are different pathologies. I'm not going to go through, I'm going to skip over these, but make sure you guys read these. Okay, the definitions and everything are there. I would look over these, you guys. For example, this one, I would probably remember, you'll probably see this image on on one of the assignments or quizzes. So this doesn't look normal, right? This is what's called esophageal varices. So esophageal varices with diffuse, round, and oval filling defects. Okay, so if you see this image, make sure that you're able to identify the pathology. Okay, I'm gonna the radiographer's responsibilities, you need to prepare the room, prepare the contrast media, obtain very good clinical history. Okay. Okay, I'm going to skip over these. Upper GI indications, gastritis, okay, acid reflux as well, ulcers, hiatal hernia, these are all, or diverticula, these are all very common for upper GIs. So this is a diverticulum here. Okay, more pathology there. I'll let you guys review that. Okay, so we're going to start with positioning. Okay, now very important, this is also a registry question. Preparation for an upper GI, NPO 8 hours. Okay, 8 hours prior to the exam, NPO, nothing by mouth. Okay, no chewing gum, no smoking. For upper GIs, NPO 8 hours. Okay, you have to ask these questions when your patient comes to the department. You have to verify and ask, have you been when was the last time you ate? Oh, I just had a burger 2 hours ago. Well, then we can't proceed with the exam. Okay, so you want to make sure that you know the prep instructions. Okay, body habit, as we mentioned, affects positioning. Let's see, this is important. I think there's another chart. So if we're doing single contrast or for barium, okay, that's going to require us to increase our technique. Okay, if we're going to do double contrast, meaning air and barium, we're going to go down on the technique, right? Because it's not going to require as much because we have air involved now. But if it's just straight barium single contrast, you will be at 100 and 125 kVp. Okay. Okay, so these are the actual projections that we're going to be doing. Okay, so for the esophagram, we're going to do an AP, a lateral, and an RAO. These are special projections. The oblique for the obliquity is 35 to 40 degrees. Okay. Okay, so we're going to start with the RAO. Again, the degree of obliquity is 35 to 40. Where are we going to center? We're going to center at the level of T5, T6. Okay, so it's really an esophagram, you guys. Positioning for an esophagram is essentially like a T-spine. Okay, place top of the IR about 2 inches above the level of the shoulders. to place center of IR at CR. Say so just like a T-spine, okay? And this is what it looks like. So on the RAO, the esophagus will be located midway between the spine and the heart. That's what you want to see. Lateral, patient in a true lateral, okay? Just like we would kind of for a T-spine, center at the level of T5, T6. And then we have what we call an upper esophagus. Let's say we're more concerned in this area, we would bring this arm back like a swimmer. So this is called a swimmer's lateral for better visualization of the proximal esophagus. Okay, this is what the lateral would look like, okay, midway between the spine and the heart. Make sure arms are not superimposing the esophagus. And then we have the AP. It says PA there, but it's usually done AP or PA. Where do we center to the mid-sagittal plane at the level of T5, T6, okay? And we're gonna cone down, right? Or you can place top of the IR about 2 inches above the shoulder. And this is what it looks like, okay? Esophagus superimposing the spine. Look at this indentation, you guys, that we talked about. What is it formed by? The aortic arch, okay? That's why that indentation is formed, because of the aortic arch that's located right there. And then this is a special view, okay, the LAO. Okay, moving on to the upper GI series projections, very important, okay? So we know we have an AP, right? AP, we have the PA, we have a lateral, it's specifically a right lateral, okay? We also have an RAO and an LPO. So we only have one anterior oblique and we only have one posterior oblique, okay? So if you, okay, let's go through them. So let's start with the RAO. The obliquity is 40 to 70 degrees. Okay, more rotation sometimes is required for heavier hyperstenic patients and less required for astenic patients. We're going to center at the level of L1. Well, where is L1? Okay, 1 to 2 inches above the lower lateral rib margin. Okay, so 1 to 2 inches above the lower lateral rib margin. Okay, and then you also want to be midway, if you look at this image, midway between the spine and the upside border of the abdomen. Now look here, astenic is going to require different centering than hyperstenic, right? So astenic, center 2 inches below the level of L1, hyperstenic, center 2 inches above the level of L1, okay? Because remember, astenic stomachs are lower, hyperstenic stomachs are higher. Okay, so this is what an RAO stomach will look like, okay? This is, I know, first of all, this is some sort of oblique. Remember, look at surrounding anatomy. We see the Scotty dog here, okay? I also see air in the fundus, okay? So this is some oblique. I'm trying to figure out if this is an AP oblique or a PA oblique, okay? Now I know this has to be a PA oblique. Why? Because there's air in the fundus. And the only PA oblique on my list is an RAO. So it's an RAO. Okay? RAO. So what you also need to know, you guys, for each projection, what is best visualized for the upper GI? Very important. And those are registry questions. On the RAO, okay, I'm going to put a star here. What's best visualized is the duodenal bulb. Okay, that's this, the duodenal bulb. And the C loop in profile. That's the duodenum, the C loop. Okay, duodenal bulb. So a question could be, when performing an upper GI, what position will best demonstrate the duodenal bulb in profile? Your answer is the RAO. Okay, Or a patient walks in with a possible ulcer in the duodenal bulb area. What position would best detect this ulcer? An RAO, okay? Then we have the PA. We're going to center at the level of L1. Okay, and this is my PA. How do I know this is a PA? Because there is air in the fundus, okay, and barium in the body. Remember, if my patient is PA, all the barium will go towards the most anterior part of the stomach, which is the body. Okay, right lateral. Patient is laying on their right side, center at the level of L1. Okay, now this image is the best, okay? So you can, that little diagram that I was showing and rotating, this is a real stomach, okay? This is a real image, okay? So this is the C, the backward C. You guys see that? And this is the spine, okay? So let me do this here. Okay, so I just want to do this again so you guys can see. So remember, so this is, imagine your patient, they're laying on their back. This is the fundus, the most posterior portion. So all the barium would go this way. And then if your patient were laying on their tummy, they would go this way, right? All the barium would fall and leave the fundus region. Okay. And then this is the C loop. This is the duodenal bulb. This is the C loop. Okay, let's go back. I just wanted you guys to have a better visualization there. Okay, so on a right lateral, what is best demonstrated? Okay, very important. The retrogastric space. Retro, behind, gastric, stomach. Okay, so here we have the stomach. Sorry, I apparently can't outline. Okay, that's my stomach, my backward C. This space, retrogastric space. Okay, and everything here on this posterior wall, that's the retrogastric space. Okay, so let's say a question says a patient is having an upper GI done for a possible, let's see, a possible diverticula in the posterior wall of their stomach. Which view will best demonstrate this condition? The right lateral view. Retro, anything posterior, the posterior wall of the stomach, in the posterior part of the stomach or between the stomach and the spine, that's retrogastric, okay? Okay, now LPO is the only anterior oblique that we're doing, okay? So there's supine. So this means that there should be, in the next slide, I should see an image with an oblique view of a stomach with barium in the fundus, right? Because they are partially supine, okay? And here it is. So we have barium in the fundus, okay? But it's also an oblique. This is not the best oblique, okay? But this is supposed to be an LPO, okay? And here we can see the duodenal bulb. Let me see. Okay, and then we have our AP level of L1, and then of course, according to their body habitus, you may have to center higher or lower. Okay, so this is AP. How do I know? Because there is barium in the fundus and air in the body. And this is AP Trendelenburg. Sometimes they do this if they're trying to demonstrate acid reflux. Okay, so they're like this Trendelenburg. Whoops.